Hello, everyone, and welcome to the Virtual Clinical Update Town Hall with Q&A. Today is Thursday, April 9th. My name is Carrie Lynn Vox, and I am the Senior Manager of Chapter and State Relations for AORN. A link to our Town Hall will be provided for you to review or share with your colleagues. 0.75 contact hours will be offered for this session, and evaluation instructions will be sent after the presentation. All attendees have been muted. This session will be dedicated to questions we have received on our nursing consult line and previous webinars, with time at the end for Q&A. To ask a question, please type it into the chat box at the bottom of your page. In the event we are not able to respond to all of your questions, we will add them with answers to our COVID-19 FAQs on AORN.org. Please review the outcomes for this webinar listed here. I would now like to introduce Linda Groh, AORN CEO and Executive Director. Linda?
They will provide the latest recommendations from trusted resources and specific evidence-based practice recommendations from the AORN guidelines. The AORN guidelines are essential in managing the epidemic in your facility. The AORN mission is to protect patient and healthcare worker safety. These webinars, as well as COVID-19 FAQs, and the toolkit on our homepage, will continue to provide you and to assist you in getting through this crisis and beyond. We know that there will come a time when hospital ORs and ASCs will need to begin managing the backlog of the canceled and delayed elective surgeries. When that time comes, you can depend on AORN to support you during that transition. I want to invite the leaders participating in this town hall to join us on Tuesday, April 14th, for a new town hall topic: leaders supporting leaders. We'll be hearing from nurse leaders who are on the front lines, working in the epicenters, who will share their experiences and lessons learned. Keep an eye on your email for this invitation. Now, let's get started. Dr. Lisa Spruce, AORN's Director of Evidence-Based Perioperative Practice, will facilitate tonight's town hall. Lisa?
Thank you, Linda. Welcome, everyone. Our panelists today are Mary Alice Anderson, Emily Jones, Mary Ogg, and Kristen Seaman. Mary Alice is a perioperative practice specialist with AORN, where she serves as a staff liaison to the AORN Nursing Research Committee and served as the lead author for the AORN guideline for pneumatic tourniquet safety. She has worked in a variety of perioperative settings and is currently pursuing a Doctor of Philosophy in Nursing Science regarding factors that affect perioperative nurse retention. Emily came to AORN from Inova Fairfax Medical Campus, a 923-bed Level 1 trauma center within the 5-hospital Inova Health System. She has worked in a variety of roles within perioperative services over her 20 years in practice. In addition to her work with Inova, she has contributed to several educational products for AORN and Fiedler Education, has served on multiple AORN task forces and committees, and has presented on a variety of perioperative topics. You may know her from one of the Hi-Fi simulations at Expo over the recent years. Mary Ogg is a senior perioperative practice specialist and has been with AORN for 13 years, concentrating on patient and workplace safety. She has authored multiple practice guidelines, developed position statements and toolkits, presented educational sessions on surgical smoke safety, sharp safety, and safe patient handling and movement, to name a few. Mary has worked on multiple surgical settings, including hospital-based ORs, ambulatory surgery centers, and freestanding office-based ORs as a scrub nurse, circulator, manager, and RN first assistant. Kristen Seaman is AORN's Clinical Perioperative Nurse Research Librarian. In this position, she leads systematic literature reviews for the AORN guidelines for perioperative practice. She joined AORN after working as a perioperative nurse in both inpatient and ambulatory settings. Since joining AORN, Kristen has written for AORN's Clinical Issues column in the journal and is one of our perioperative nurses who answers member questions on the Nurse Consult line and OR Nurse Link. Our entire nursing practice team has been going through submitted questions and will be answering as many as we can tonight. If we don't answer your question, please check our COVID-19 resource page where you will find an ongoing list of frequently asked questions and answers. Please enter additional questions in the chat box, and remember, you can always call the clinical consult line and we will be happy to talk with you directly. Mary Alice, we'll start with you.
Thank you so much, Lisa, and thank you everyone for your work during the COVID-19 pandemic. I'd like to discuss self-care with you today, as many of our members and allies have questions regarding this topic on the consult line. We must make time for ourselves, and I'd like to review some best practices for you. The best practices in self-care have been studied for years, and really self-care is very personal and requires trial and error to find the best interventions for yourself. I'll answer a few questions that we've heard, but please know that there are many other practices that could be more beneficial to you and your family. First, what can I do for in-the-moment, quick self-care? Deep breathing and relaxation techniques, such as mindfulness and positive self-talk, can be done before, during, and after stressful encounters for a quick break. For instance, you can do a 4-count breathing, which is used to reduce stress in combat. This is basically taking 5 breaths by visualizing 1, 2, 3, 4 when you need a reset. Let's practice. Breathe in with me by counting 1, 2, 3, 4. Stop and hold for 1, 2, 3, 4. And exhale, counting 1, 2, 3, 4. Also, you can take a moment to stretch and acknowledge your work, mindfully clench and release your hands, or declare an aspiration of loving kindness to yourself and others, such as may I be happy, may I be well, may I be filled with kindness and peace. Another question is that, we should limit caffeine and alcohol as part of successful self-care strategies, but what else can I do to decrease my stress when I'm not at work? Though caffeine and alcohol may provide short-term comfort, the long-term effects to your health may limit your resilience to stress. Take time to reflect on your day through meditation or writing. Talk about your feelings and experiences to supportive friends and family as well. Maintain a diet, exercise, and sleep routine that's healthy as possible. And also remember that you can combine these practices. For example, you can practice gratitude and self-affirmations while practicing yoga. You can talk about your experiences and stretch while cooking dinner with the family. Or you can meditate and use sleep music and aromatherapy before bed. We've also heard, is it wrong for me to take a break? So you can continue to help others long-term. It is very important for you to know your boundaries and that it is okay to take care of yourself before you experience symptoms of burnout or secondary traumatic stress. Signs of burnout include feelings of sadness, depression, apathy, being easily frustrated, blaming others, and irritability, lacking feelings or indifference, feeling isolated or disconnected from others, even having poor self-care, feeling tired, exhausted, or overwhelmed, or feeling like you're a failure or you're not doing your job well. Signs of secondary traumatic stress include excessively worrying or fearing about something bad happening, being easily startled or being on guard all the time, any physical signs of stress that include racing hearts, having nightmares or recurrent thoughts about traumatic situations, or feeling that others' trauma is yours. Please practice safe care before you feel any of these symptoms, and if you do feel any of these symptoms now, please start utilizing self-care techniques or reach out for help. Some other questions is, how can I help my team if I'm the leader? Supportive leadership has the potential to make or break a team. While some teams may be used to completing tasks more independently, during a crisis, it is important that leaders facilitate shared responsibilities, as well as recognizing when there may be more severe responses from one or more team members in order to direct them to professional assistance if needed. Leadership can also encourage breaks, limit voluntary overtime, and create a culture of respect and open communication for team members to ask for breaks and discuss their concerns. The CDC also suggests developing a buddy system in which coworkers are partnered up with each other to support each other at work. Buddies can identify each other's strengths and weaknesses and share their stress relief tactics. They can observe each other during work hours for an increase in stress and help each other out. They can set up check-in times to listen, share, and recognize good and bad situations and advocate for each other as needed. Another question is that people are worried about transmitting the COVID-19 to their families, and they're feeling very distressed and maybe even guilty if they try to reach out to other people. Utilize the regulated precautions at work and practice physical distancing at home if you feel anxiety about possibly transmitting COVID-19 to your family. If distress impacts activities of your daily life for several days or weeks, please talk to a clergy member, counselor, or doctor. And you can also contact the SAMHSA helpline at the number on the screen. Again, it is critically important to understand that to best care for your patients, you must take care of yourself first. We're in this for the long haul, and our individual and collective effort is making a difference. We also had a couple of miscellaneous questions about safe perioperative practices when caring for patients who test positive for COVID-19. One of these is whether sterile processing technicians need to wear an N95 mask when decontaminating surgical instruments that were used on a patient that tests positive for COVID-19. An N95 respirator is not needed in the decontamination area for protection from SARS-CoV-2 because it is a lipid-enveloped virus that is susceptible to detergents and disinfectants that are already used in these decontamination areas. Sterile processing personnel who perform decontamination should wear PPE consistent with the guideline for cleaning and care of surgical instruments, including a fluid-resistant gown with sleeves, gloves that extend beyond the cuff of the gown, a mask with a fluid barrier rating, eye protection or a full face shield, and shoe covers or boots designed for use as PPE. Instruments and devices that have been used in the procedure for patients with known or suspected COVID-19 should be handled the same as any other instrument. The recommendation to perform brushing only below the waterline with hand washing is not a new recommendation, but it is especially important now because brushing above the waterline can produce aerosols, and the risk of these in the context of COVID-19 is unknown. Personnel responsible for reprocessing should always be consistent with the personnel safety recommendations in the AORN guidelines for cleaning and care of surgical instruments, sterilization packaging systems, and sterilization. Another frequently asked question is what if a patient is diagnosed with COVID-19 and is intubated in another room and then transferred to the OR suite? Does the OR team need to wear an N95 or PAPR for the surgical procedure, or can they wear a regular surgical mask? If a surgical N95 respirator is available, everyone in the room should be wearing one. The current CDC recommendations are that a respirator is preferred over other masks when caring for a patient with known or suspected COVID-19. However, the CDC does give the option of a face mask in the event that a respirator is not available due to supply shortages. The CDC recommends prioritizing respirator use for personnel who will be present in the room during aerosol generating procedures performed on a symptomatic COVID-19 patient. The World Health Organization also recommends using an N95 or equivalent respiratory protection if aerosol generating procedures are performed. Finally, is it better to designate a dedicated team or designate an OR room for all COVID-19 cases? Some guidelines and protocols have been published by the American College of Surgeons, the Canadian Anesthesiologist Society, and Nebraska Medicine that suggest that the use of a dedicated COVID-19 OR and team are recommended. Each facility will need to develop their own protocol based on the availability of OR staff, equipment, and supplies, the number of operating rooms, and the prevalence of disease in their region. Now I'll turn it over to Emily.
Thank you, Mary Alice. We received several questions from our nurses interested in preventing the spread of the coronavirus, including what is the best way to clean lead aprons if used for radiation protection on COVID-19 patients? What can we do to help keep our families safe and not bring this home to them? Should we be laundering our scrubs at home? And if nurses and staff are floated to other floors to assist with presumptive and positive COVID-19 patients, is it safe for that staff to return to the OR on the same shift? First, we'll discuss disinfecting lead aprons if used to protect a patient. The AORN guideline for radiation safety provides recommendations to minimize radiation exposure to the patient. One strategy includes covering areas of the patient outside of the direct radiation beam with lead or lead equivalent shielding. For patients who require this shielding during certain procedures and who may have the coronavirus, the lead shielding should be cleaned and disinfected according to manufacturer's instructions. The coronavirus is an enveloped virus, which makes it easier to destroy with the appropriate EPA-registered disinfectants. You can find List N, products with emerging viral pathogens and human coronavirus claims for use against SARS-CoV-2, including those appropriate for porous surfaces, linked through the CDC. Assemble an interdisciplinary team, including your infection preventionist and radiation safety officer, to assure the appropriate disinfectant is being used for the shielding devices you have in your facility. As the covering is often a porous material, be sure to allow the disinfectant to dry completely and store the aprons and thyroid shields in a manner that prevents folding or creasing. You may also consider protecting the lead shielding with a fluid-resistant cover, such as plastic sheeting material, to prevent contamination. Now, let's talk a little bit about ways to prevent bringing the virus home. The AORN guideline for transmission-based precautions provides guidance on standard precautions and includes specific strategies, such as those that should be implemented for airborne and droplet precautions. The appropriate use of PPE, such as gowns and gloves, may limit contamination to healthcare personnel clothing, such as scrub attire worn in the operating room. Of course, if clothing becomes contaminated with blood, body fluids, or other potentially infectious material, you should change and replace with clean attire as soon as possible. In situations where hospital laundered scrubs are not available, a facility may consider disposable scrubs for employee use. If staff members are floating to other areas of the hospital to care for infected or potentially infected patients, they should follow hospital policy on attire and change if attire is contaminated before returning to the perioperative area. Some things to remember too as you leave work to return home. Frequently disinfect your cell phone. Think about leaving personal items at home. Have hand sanitizer easily accessible. Consider changing clothes and shoes, those you wore to and from the hospital, and washing them right when you get home. Shower as soon as possible, and wash your hands all the time. And of course, always monitor yourself for symptoms of illness. Kristen will give some additional tips on this. Now, let's move on to opportunities for OR nurses to expand their knowledge if asked to float to other areas of the hospital. A couple of the questions answered here include, what are hospitals doing to prepare their OR staff to help with the influx of patients? And does AORN have any recommendations for preparing OR nurses for auxiliary roles in ICUs or ERs to assist with COVID-19 patients? During this time, hospitals may need to prepare staff members to respond to the influx of patients due to the COVID-19 pandemic. Many of these patients may need medical care rather than surgical care. We may be asked to assist in a critical care setting or perhaps in testing of symptomatic patients. Perioperative nurses are experts in infection prevention, sterile technique, donning and doffing PPE, team communication, patient positioning, and preventing cross-contamination, just to mention a few. Consider the knowledge and skills the perioperative nurses can share with other specialty areas to assist with the care of these patients. Other options to prepare staff may include cross-training in other specialty areas, such as in critical care or in the emergency department. The American Association of Critical Care Nurses, AACN, has made online training modules and resource documents available to non-members during the pandemic to provide needed education for nurses. Register for their COVID-19 pulmonary, ARDS, and ventilator resources e-learning by creating a free account at aacn.org. Also, the Society of Critical Care Medicine has additional free virtual critical care education courses for the non-ICU clinician during this COVID-19 pandemic, available at sccm.org. Of course, always consult your local hospital policies and health department or state board regulations for guidance on scope of practice during this pandemic. AORN, of course, has many resources linked through the COVID-19 page. And remember, for those in leadership, AORN will also be hosting a leadership town hall on Tuesday, April 14th from 6 to 7 p.m. Mountain Daylight Time. Please visit aorn.org for more information. Now, I'd like to hand the presentation over to Mary.
Thank you, Emily, and thank you to all of you caring for our patients. You have my deep admiration. I will be discussing two hazards related to COVID-19 virus. One is the inhalation of surgical smoke, and the other is moving patients. We have received multiple questions around inhalation of surgical smoke when caring for a patient that either has the virus or is suspected of having the virus. The first question is, what are AORN's recommendations for evacuating surgical smoke on a known or suspected COVID-19 patient? Well, AORN has and will continue to recommend that the evacuation of all surgical smoke on all patients on all cases. Multiple research studies have demonstrated that surgical smoke contains viruses, bacteria, hazardous chemicals, ultrafine particles, and cancer cells. At this time, with a lack of research studies, it is unclear if the virus that causes COVID-19, SARS-CoV-2, can be transmitted through surgical smoke. But new information regarding the virology of severe acute respiratory syndrome coronavirus and the disease COVID-19 is evolving. Recently, the Society of American Gastroenterologists and Endoscopic Surgeons, SAGES, released a statement that the best practice for mitigating possible infectious transmission during open, laparoscopic, and endoscopic procedures is to use a multifaceted approach, which includes proper room filtration and ventilation, appropriate PPE, and smoke evacuation devices with suction and a filtration system as available. These recommendations from SAGES is consistent with AORN's and the CDC's recommendations for smoke evacuation. Well, what do we know regarding the SARS-CoV-2 and where it is found in the body? This RNA virus has a size range of 0.06 to 0.14 microns. Along with the nasopharynx, the upper respiratory tract, and lower respiratory tract, the virus has been found in the entire GI tract from the mouth to the rectum. The virus has been found in nasal swabs, saliva, sputum, throat swabs, blood, bile, and feces. Urine and cerebral spinal fluid evaluations have been negative so far. So the virus has also been found within the cells lining the respiratory tract and the GI tract, and it is suspected that the virus has multiple modes of transmission. We already have known that there has been viral transmission of the human papillomavirus, HPV, after inhalation of surgical smoke. So the next question is, if a smoke evacuator is recommended to contain surgical smoke, we wonder if we should use a smoke evacuator during intubation and extubation, holding the tubing close to the patient's mouth. Well, currently there is no literature or research to support using smoke evacuators in this manner. Also, the smoke evacuators have not been tested and approved by the FDA for this type of application. Please check with your manufacturer of your smoke evacuator for further direction. If possible, you may have heard this many times before though, to intubate your patients in a negative pressure room or airborne infection isolation room, and then transfer them to the positive pressure OR. Once intubated, they are considered low risk because it is a closed system. Also, consider transferring the patient to a negative pressure room for extubation. If a negative pressure room is not available, supplemental air cleaning technologies, such as a HEPA filtration device, may be used. The HEPA filtration unit should be used during aerosol generating procedures, such as intubation, open suctioning, bronchoscopy, and cough-producing procedures. In consultation with your facility engineering department, placement should be determined, preferably near the patient's breathing zone. Once the patient is intubated, and if there are no cough-producing procedures occurring, the HEPA filtration unit may be switched off. However, it would be important to turn that unit back on if the patient is to be extubated or if a cough-producing procedure will occur. We're moving on to education. Does AORN have plans to educate its membership about the risk of viral transmission during surgery, both open and laparoscopic, as a protective measure to minimize COVID-19 spread? AORN has several existing educational programs on surgical smoke available to our members. The AORN Toolkit for Management of Surgical Smoke has a 5-part webinar series on surgical smoke that includes information on the hazards and the importance of evacuation. A recorded webinar is available on the AORN website, providing an overview of the AORN guideline for surgical smoke safety. We also have resources and tools that are available in the Guideline Essentials for Surgical Smoke. And then a key element of the AORN Go Clear program is the 6 online education modules. And finally, AORN has been providing education sessions on surgical smoke and the hazards at our annual conferences and guideline implementation workshops across the country for the last several years, and which we do hope to reinstate in the future when things settle down. We've had a few questions about the filters in the smoke evacuators. Do the filters in the smoke evacuator need to be changed after the smoke evacuator is used on a diagnosed COVID-19 patient? Well, we need you to check with your local product representative and/or the manufacturer of your smoke evacuation devices for their specific instructions for use regarding filter changes. Your manufacturers are your best resource for this information. Several manufacturers are sending letters to their customers and providing guidance and resources on their websites regarding COVID-19. If you have not received this information or this letter, again, contact your local product representative and the manufacturers. So, how do I dispose of a used smoke evacuator filter after use on a COVID-19 patient? As surgical smoke contains potentially infectious material such as viruses, bacteria, blood, and cancer cells, OSHA and the AORN guideline for surgical smoke safety requires that the used filters, tubing, the electrosurgical pencils with evacuation tubing be handled using standard precautions and disposed of as biohazardous waste. And our final filter question is in regards to, they've been using a low pressure Neptune, which notes a micron filter of 1.2, rather than the wall suction for deflation of the pneumoperitoneum. What are your thoughts on this? Questions on this specific equipment and any of your questions about your equipment and filters should be directed to the manufacturers of your equipment. Stryker, the Neptune's manufacturer, has sent guidance to their customers on equipment specifications regarding the insufflators and filters. We've received several questions about laparoscopic procedures. In SAGES, the European Association for Endoscopic Surgery and the Canadian Association for General Surgeons have recommendations for reducing the risk of aerosolization during laparoscopy. This is detailed information that can be found on the SAGES website, and also links will be provided in the FAQs on the AORN website to the SAGES website. And this is very detailed, and again, I urge you to go to the website and print it out for yourself for reference. But first, all pneumoperitoneum should be safely evacuated from the port attached to the filtration device before closure, trocar removal, specimen extraction, or conversion to an open procedure. Once placed, ports should not be vented if possible. If movement of the insulating port is required, the port should be closed prior to disconnecting that tubing, and the new port should be closed until the insufflator tubing is connected. The insufflator should be on before the new port is open to prevent gas from backflowing into the insufflator. The patient should be supine and the least dependent port should be utilized for desufflation. During desufflation, all escaping CO2 gas and smoke should be captured with an ultrafiltration system, and the desufflation mode should be used on your insufflator if it is available. If your insufflator does not have a desufflation feature, be sure to close the valve on the working port that is being used for insufflation before the flow of CO2 on the insufflator is turned off, even if you have an inline filter in the tubing. Without taking this precaution, contaminated intra-abdominal CO2 can be pushed into the insufflator when the intra-abdominal pressure is higher than the pressure within the insufflator. Surgical drains should be utilized only if absolutely necessary. Suture closure devices that allow for leakage of insufflation should be avoided. The fascia should be closed after desufflation. Hand-assisted surgery can lead to significant leakage of the insufflated CO2 and the smoke from ports and should be avoided. If it is used to remove larger specimens, it can be done after desufflation, and then the specimen can be removed and the closure performed. This is a graphic from the SAGES and the European Society with their COVID-19 recommendations. It's very high level, but gives you a little brief overview of the different things to take. As I mentioned earlier, they stress using PPE during laparoscopy, having a filter, and well as other measures for during endoscopy. This is also available on the SAGES website, and it's just a little helpful reminder of some of the things to follow when you're doing laparoscopic cases. And there have been a few questions submitted regarding safely moving patients and protecting our OR team. First is, what is AORN's recommendation for using an air transfer device for a known or suspected COVID-19 patient? Well, AORN recommends that each facility base their decision to use an air transfer device for a known or suspected COVID-19 patient on a risk assessment by an interdisciplinary team, weighing the potential risk of contamination when using this device against the potential musculoskeletal injuries of moving a patient manually. Any air movement from an air-assisted device will keep the virus in the air for a longer period than if there was no additional air movement due to the size, weight, and aerodynamic properties of the virus. Some air-assisted transfer devices have HEPA filters that filter the air before the air enters the device system, that is, the blower, the hose, and the mattress. The size of the COVID-19 virus is approximately 0.125 to 0.140 microns. The capture size of the HEPA filter is 0.3 microns. When using a device without a HEPA filter with a known or suspected COVID-19 patient, the contaminated air can enter the device and be forced back into the room through the holes in the mattress. Contamination may be minimized with both types of devices if the blower is used after the patient is intubated, before the patient is extubated, and the correct number of air exchanges and time has elapsed. Again, follow your manufacturer's instructions for use for cleaning and decontamination. Please refer to the guideline for safe patient handling and movement for additional information on assessing the patient and developing a plan of care for safe patient handling. Contact your device manufacturer for guidance and filtration specifics. And finally, consider alternatives to the air transfer device, including using slide sheets, slide boards, and rollers. And our final question in this section are, what are the recommendations for PPE when moving a patient using a roller or a slide sheet with the virus? When manually moving a patient with known or suspected COVID-19, healthcare personnel should follow standard, contact, and airborne precautions. Healthcare personnel who are in the room of a patient with the known or suspected virus should adhere to standard precautions and use a respirator or a face mask, gown, gloves, and eye protection. When available, respirators instead of face masks are preferred. They should be prioritized for situations where respiratory protection is most important and the care of patients with pathogens requiring airborne precautions. And now it is my pleasure to turn the presentation over to Kristen Seaman.
Thanks, Mary. Hi, everyone. Thanks for joining us this evening. I'm going to talk about a variety of topics, and we'll start with some PPE, or personal protective equipment questions. First one, I just read where COVID can live on the bottom of your shoes for hours. Shouldn't we be using shoe covers for each case and then take them off before leaving the room? What guidance is there on booties? The answer is that COVID-19 is caused by a respiratory virus. And for it to infect a new host, it must enter someone's nose, mouth, or eyes through inhalation or through direct contact with respiratory secretions. In other words, there would have to be a way for COVID-19 to get from the floor up to someone's eyes, mouth, or nose. Nevertheless, in procedures with large amounts of irrigation, staff may want to wear them. Booties or shoe covers are considered PPE to protect healthcare providers from blood and large amounts of body fluids or irrigation, such as in arthroscopy procedures or body fluids like amniotic fluid. It's important to remember that the floor is always considered dirty. Once we clean or disinfect it, it's dirty yet again as soon as we step on it. So dedicated work shoes would be more appropriate. Disposable shoe covers are problematic for a couple of reasons. First, they would have to be designed for PPE, heavy and protective, to be of any help. The super thin ones that are seen throughout facilities and sometimes in homes are not considered protective wear. Second, wearers would have to take them off and put them on before entering or exiting the operating room to provide any benefit of containing the pathogens to the room. Unfortunately, it is widespread in practice to wear them all over the facility. At the end of the shift, providers put on street shoes and walk right over where everyone else was walking around with their shoe covers on. The bottom line is to always consider the shoes and the floor as dirty. One of our infection preventionist nurses told me that while in clinical practice, she left her hospital shoes at the facility, wore separate driving shoes home, and left those in the garage. And that's one strategy to kind of contain any pathogens to the facility. Okay, another PPE related question. Does PPE used when caring for suspected or positive COVID-19 patients need special handling for disposal, or can it be disposed of in regular garbage? According to the most recent information from the Centers for Disease Control and Prevention, management of medical waste can be performed in accordance with routine procedures as outlined in your state and federal regulations. This directive also includes laundry. There is no evidence that novel coronavirus needs additional treatment. Okay. And another question. We are hoping this will cover current PPE recommendations for the operating room when providing surgical care of a known or suspected COVID-19 patient versus a patient not exhibiting signs or symptoms, including PPE worn by anesthesia providers, circulating RNs, etc., during intubation, surgical procedures, and transport to PACU. The answer is the American College of Surgeons has stated that procedures on known or suspected COVID-19 infected surgical patients should be done with full PPE and an N95 mask or powered air purifying respirator, which is sometimes called PAPRs, PAPR. Team members who are not present in the room may wear the protection that they usually wear. Surgical masks, for example, as long as the procedure itself is not aerosol generating. For transport personnel, the CDC recommends the use of a face mask by the transporter for anything more than brief encounters with COVID-19 patients. Additional PPE, such as a gown and gloves, should not be required unless there is an anticipated need to provide medical assistance during transport, like helping the patient replace a dislodged face mask. Okay. Another person asks, how about pre-op and PACU nurses' preparations? In pre-op, ensure rapid safe triage and isolation of patients with symptoms of suspected COVID-19 or other respiratory infection, such as fever or cough, prioritizing triage with these patients. Also, be sure to have a supply of face masks and tissues for patients, as well with respiratory symptoms provided at check-in. Ideally, COVID-19 inpatients should bypass pre-op and go straight to the operating room. If the patient is presenting to pre-op for surgery, place the patient in a negative pressure airborne infection isolation room. Some facilities may not have these rooms available. If a doored examination room is available, isolate the patient with the door closed. Otherwise, create a separate, well-ventilated space for symptomatic and suspect COVID-19 patients that separates them from other patients by 6 or more feet, with easy access to respiratory hygiene supplies. Another option for pre-op is for the facility to allow waiting patients to remain in a personal vehicle or outside where they can be contacted by mobile phone when it is their turn to be evaluated. For PACU patients, the American Society of Anesthesiologists advises against bringing a COVID-19 patient into the PACU. Instead, the patient may be recovered in the operating room or moved to another designated operating room for anesthesia recovery. Ideally, the patient would be extubated and recovered in a negative pressure airborne infection isolation room. Next, I have a couple of questions related to transmission of COVID-19. Why is it droplet precautions unless we are doing an aerosolizing procedure? Should we not be wearing an N95 mask when caring for a confirmed or suspected COVID-19 patient? Yes, you should be wearing an N95 during care for a confirmed or suspected COVID-19 patient. Healthcare workers who enter the room of a patient with known or suspected COVID-19 should adhere to standard precautions and use a respirator or face mask, gown, gloves, and eye protection. Respirators are preferred over face masks. They should be prioritized for care of patients with COVID-19, specifically those undergoing aerosol generating procedures. If an employee does develop COVID-19, is then quarantined for 14 days, can the employee recontract the COVID-19 virus? Is another question we've been asked. The answer is, unfortunately, this is one of the characteristics of the novel coronavirus that we have not yet determined. According to the Centers for Disease Control and Prevention, Middle East respiratory syndrome patients aren't likely to be reinfected, but we don't yet know whether recovered COVID-19 patients have the same benefit of immunity. Next, I'm going to answer some questions about masks, which has been a hot topic, and setting up the operating room. First, I will tackle the mask questions. Do you have a statement on the proper use and efficacy of the DIY homemade masks that people are making? When is the appropriate time to use them? And what are their limitations? Much of the community is being recruited to make these masks due to the shortage of proper N95s, but not sure if the general public is aware of their limitations regarding use. Also, what is AORN's position on cloth mask use in the operating room? Again, this has been a hot topic lately. According to the Centers for Disease Control and Prevention statement that was updated on April 3rd, the cloth face coverings recommended are not surgical masks or N95 respirators. Those are critical supplies that must continue to be reserved for healthcare workers and medical first responders, as recommended by current CDC guidance. The CDC now recommends wearing cloth masks for the general public in public settings where it's difficult to maintain proper distance, such as when they must go out to the grocery store or pharmacy, and especially in those communities where transmission is substantial. Cloth face coverings should not be placed on young children under age 2, anyone who has trouble breathing or is unconscious, incapacitated, or otherwise unable to remove the mask without assistance. Cloth masks should not be used by healthcare personnel because they are not considered PPE. Do not use them as PPE. The CDC recommends use of cloth masks for the public, but not for healthcare personnel. For healthcare personnel, the use of homemade masks is included in crisis capacity and should not be used unless there are no other options available. For more detail about mask selection, please see the AORN COVID support page. For the FAQ, we have a shortage of surgical masks and/or respiratory protection. What should we do? Next mask question. Due to the mask shortage, I've been asked if circulating nurses can forego wearing masks or wear homemade masks. What is AORN's statement on that? Again, this is not advisable. The CDC has a resource that details strategies for coping with supply shortages and absences. they've categorized supply issues into 3 categories: conventional, contingency, and crisis capacities. If your healthcare facility is in a crisis capacity, that means strategies that are not commensurate with United States standards of care. Measures suggested, or a combination of these measures, may need to be considered during periods of known face mask shortages. Assuming that your facility has already examined its mask supply chain, utilization rate, identified and contacted emergency suppliers, and implemented engineering controls such as reducing the number of patients entering the facility, and educated staff and verified competency on correct use, facilities may consider using contingency or crisis strategies. Some of the contingency capacity procedures include canceling all elective and non-urgent procedures and appointments for which a face mask is typically used by healthcare providers, or by limiting the reuse of masks. Face masks should be prioritized to selected activities, such as provision of essential surgeries and procedures, care activities where splashes and sprays are anticipated, activities where prolonged face-to-face or close contact with a potentially infectious patient is unavoidable, and if filtering face piece respirators are no longer available for performing aerosol-generating procedures. AORN's infection preventionists have created a table that combines AORN's and CDC's guidance on coping with different levels of PPE shortages. This can be found by expanding the 3rd question on AORN's COVID-19 FAQ page. The CDC has also created a burn rate calculator, which allows facilities to determine how long their supplies will be expected to last. This link is available on AORN's COVID-19 toolkit, which can be found on our homepage, aorn.org. Here's a question that I got asking about general OR setup. Is there a document that has been created as an example for a protocol or guideline describing roles and responsibilities of all team members and how to prepare the operating room for a COVID case using a negative pressure anteroom, including all steps for equipment, supplies, charting, communication, transferring, transporting, recovery in anteroom, etc. Nebraska Medicine has a detailed document that outlines roles and can be used as a model for COVID-19 surgical procedures. For example, here are some initial steps listed once a patient has been transported to the operating room. Transporters and patients will enter the OR and allow the door to close. Then, after the patient transfers to the OR table, the bed or gurney will be cleaned and moved to the appropriate location outside of the OR. Next, the circulator will remain clean and wear gown, gloves, eye protection, and N95. Then, the mobile supply cabinet will be stored in the core and accessed by a designated runner. The American College of Surgeons has a list of things that staff can do to prepare an OR for a procedure with a suspected or known COVID-19 patient. Among those steps, the ACS suggests the use of a negative pressure anteroom. A runner should be poised outside the OR and only one door open to move any supplies or equipment from the anteroom to the OR at one time. The key is to keep all door openings to a very minimum. Use of a runner will allow the circulator to keep their PPE on and decrease the number of door openings. Lastly, I've been hearing more questions about care for obstetric COVID-19 patients. This person asks, how do you handle a positive COVID-19 patient that needs a C-section? Are there guidelines out there? We are a critical access hospital. Thanks for any help you can give us to set up the scenario. The answer is AORN's COVID-19 Toolkit contains a link to the CDC's document called Interim Considerations for Infection Prevention and Control of the Coronavirus Disease 2019, COVID-19, in Inpatient Obstetric Healthcare Settings. These guidelines will help you safely care for obstetric patients. One of the first things that the obstetric patient who is confirmed or suspected COVID-19 or the medical transport personnel should do is alert the obstetric unit of her impending arrival. This notification will allow the unit to gather PPE and alert healthcare personnel on the team who will be caring for her. The American College of Obstetricians and Gynecologists also suggests that infants born to mothers with confirmed COVID-19 should be considered persons under investigation, or PUIs, and should be isolated according to the Infection Prevention and Control Guidance for PUIs until the mother's transmission-based precautions are discontinued. The literature is not currently clear as far as whether COVID-19 can cross the placenta. However, a case series showed that infants born to infected mothers did not test positive for the coronavirus. I hope that these questions and answers will help you in your practice. I'm now going to turn things back over to Dr. Spruce.
Thank you, panelists. Thank you all. We are out of time. I hope we answered many of your questions, but for those we were unable to get to, our perioperative nurse specialists will review to provide answers and add to our FAQs on the AORN homepage. I hope you are all connecting frequently to our FAQs and the toolkit. They are updated daily. And remember too, AORN members are encouraged to join the discussions on OR Nurse Link. Thank you for being with us. We wish you a good night.